Okay, welcome everyone to week one. I hope you had a good holiday, and I also hope that you had a really good first day today. I made a post on Facebook, and that shows you, I put in a little bit of information for you guys, like how you'll be focusing a lot more on CLIN skills and anatomy this semester. And we'll be taking you through that this semester, so don't worry about that. Just take each week as it comes, and then you should be okay. If you have any questions, you can always text any of us. My messenger is always open. So if you have questions about SEM 2 or just about content, you're welcome to text me at any time. So we're going to run through PHYS POP. POP means population health. It's sort of like HKS to some degree. Anatomy, you'll be introduced to anatomy for the first time. And CLIN skills, we're going to be doing history taking. So PHYS Intro to Motor Systems. Here you can see that there are specific areas of the brain that are specific for different functions. So on this right diagram, you can see that there's frontal for motor function, motivation, aggression, smell, and mood. And the same applies to parietal, temporal, and occipital. On the left, this is a diagram from your lecture. It's sort of the same thing. And so what you'll need to know from here is just that different functions come from different areas of the brain. We're also going to be talking about the peripheral nervous system. So just to recap, sensory is afferent, A, and motor is efferent, E. Think of afferent, A comes before E in the alphabet. So sensory goes from the outside to your spinal cord, and then motor goes from your spinal cord out to your organs. In sensory, you've got somatic afferent fibers. These are impulses from your skin, your skeletal muscles, and your joints. And then you've got your visceral afferent fibers. These transmit impulses from visceral organs. On motor division, you're carrying impulses away from your central nervous systems to your organs. And we're also introduced to a new term, alpha motor neurons. These are involved in all movements that are both voluntary, so things you choose to do, and reflexive. That's what you don't choose. And it's also in the neuromuscular junction too. So neuromuscular, nerves to muscle. So it's the final point where the nerves contact the muscle. Differences in motor unit properties. So you'll also need to know the difference between a motor unit and a motor neuron pool. Think of a motor unit as one neuron, and one neuron, like have a look at this blue one here. It innervates a lot of the fibers, this blue one, this blue one, this blue one. That's a motor unit, all of the ones that are associated with this nerve. Then you've got a motor neuron pool. That's all of the alpha motor neurons that innervate that muscle. So remember, alpha motor neurons were the nerves that are connected or that innervate specific muscles. And so a motor neuron pool is if you look at a specific nerve, say like this green one, and you consider all of the different nerves that innervate that one muscle fiber. That's a motor neuron pool. And then now I'm going to talk about the controlling the force of the sort of like the action potentials. And so you've got three things we need to know: a twitch, which is something that happens once; an unfused tetanus, which is something that happens multiple times, so the frequency is greater; and you've got fused tetanus. Think of fused tetanus as unfused tetanus, but it happens so frequently, like so many action potentials are being fired, that it becomes a smooth increase like this. So another way of controlling the force, if not by increasing the rate or increasing the frequency, is by increasing the size. So if you have something more powerful, you'd need more like larger motor units. And if you need something that requires less energy, a smaller motor unit. So with a smaller motor unit, you've got smaller cell bodies and innervating fewer muscle fibers. With a large motor unit, you've got large cell body innervating many muscle fibers. And small motor units are recruited first. So here, if the x-axis is time, you're recruiting small units first, and then eventually over time you increase more motor units. You've also got number of motor neurons. So with recruitment, we call this spatial recruitment. As the force increases, the percentage of motor units recruited also increases. Remember that you will revisit different types of muscle. And so the three you need to know is smooth muscle, seen in the GIT, in the bladder, cardiac muscle, seen in the heart. This has branched features, and skeletal muscle as well, with lots of mitochondria, and they are striated.
Okay, so I'm going to be covering pop health. This week you would have had your introduction lecture. So pop health is kind of like HKS in that it somewhat focuses on disease epidemiology, but it's different in that there's a lot more focus on calculations and the actual science behind disease. Whereas if you do HKS, it's more of the equity and it's less calculations basically. Now, population health is actually kind of important for you guys this semester. So on your end of your exam, it's going to be around 20 marks on your exam 2 from my memory. So it is kind of a big chunk, but it's pretty palatable. So if you study the right way, it's actually pretty, it's one of the nicest subjects this semester. So yeah. So the basic definitions for pop health, or health, you would have seen this in HKS, but a state of complete physical, mental, and social well-being. It's not merely the absence of disease or infirmity, but it's all three aspects. So population health, the three main focuses are really important actually, and they'll keep coming up again and again throughout the lectures, but they are to improve health, reduce health inequalities, and focus on the entire population rather than individual cases. So population health is definitely much more broad, and you'll see that as you go. Now, the main things that you're going to be using to to learn population health are going to be epidemiology and biostats. So epidemiology, just know the definition. It's not that important, but it's just a study and distribution of determinants of health and disease in populations, and the application of this study to control of health problems. Now, these definitions aren't that important. You don't really need to memorize them, but it's just kind of for your overall understanding of the broad spectrum of pop health. Okay, next. So causation. This is the first thing that's kind of important. You will get examined on this, so it's good to understand. So something that either alone or in combination with other things produces an outcome. So the best example was actually in the lecture slides. Basically, there's two types. So there's sufficient and necessary. So if something is sufficient, then that means that this alone can cause the disease. And necessary means it is needed to cause the disease, but the disease doesn't have to happen if you have it. So I know that they sound kind of similar, but if you look at the examples here, I think it kind of clears it up a bit. So tuberculosis or TB. So it is necessary to be exposed to Mycobacterium tuberculosis, but I don't know if you should know this, but almost everyone, or like a lot of people have been exposed to Mycobacterium tuberculosis, but not all of them have TB. So it's not sufficient to cause the disease, but everyone who has TB has Mycobacterium tuberculosis, so it's necessary. Cigarette smoking is neither necessary nor sufficient for the development of lung cancer. I feel like I've seen that question lots and lots of times, so just keep that in mind, I guess. It's kind of high yield. So because you can get cancer without smoking, and yeah. Like an example of something that's necessary and sufficient is having the Ebola virus to develop Ebola fever. So you need the Ebola virus, and it is enough to cause the disease. So that's necessary and sufficient. Okay, so next thing is risk factors. This is kind of low yield stuff, but just for the sake of completion. So there's 4 main risk factors here. So we've got predisposing, enabling, precipitating, and reinforcing. You kind of need to know the definitions of these. So kind of just trying to understand, predisposing means stuff that's like not really in your control, like your age or your genetics. Beliefs is something that's kind of like an iffy one, but if you're born into a culture and that's how you've been raised, then that's kind of also predisposing. Enabling is stuff that kind of helps to make you more susceptible to having a disease, like having low income or having a poor nutrition. So it's not necessarily that it's the cause directly, but it definitely contributes to having more non-communicable diseases. Precipitating means basically just you've been exposed to the disease, and reinforcing is repeated exposure. So if you just keep those 4 definitions vaguely with you, that's good. It's not that important. What is important is some statistics here. So non-communicable diseases are causing 71% of the world's death in 2015. I don't know if in this year's lecture slides that's been updated, but for our ones, that was the statistic that we had, and there was a few quiz questions that included that. So, you know, again, some random stats that they bring up in exams. So the 4 main diseases are CVD, or cardiovascular disease, diabetes, chronic lung disease, and cancer. So non-communicable disease means something that can't be shared, and it's the cause of 71% of the world's deaths. Now, the 4 main uses of, the 4 main causes of NCDs are tobacco use, physical inactivity, unhealthy diet, and the harmful use of alcohol. Again, it's in bold because that's kind of examinable content. It's kind of high yield, so just keep that in mind as well. Okay, so this stuff is where this topic kind of differentiates itself from HKS. So calculating risk. So this is going to be something you do have to know these formulas because it will come up in your exam, but there's other formulas that you'll need that come up later. But this is more stuff that you'll use for your population health assignment or your EPI assignment. So what are these things? So basically, relative risk or risk ratio is basically what's the risk of me getting an illness if I've been exposed compared to, let's say, Ethan and he hasn't been exposed. Okay, so you just divide it. Yeah, that's the formula. It's the risk of exposed over risk of unexposed. Now, risk difference over attributable risk basically means what's the difference between someone who's you just subtract the risk of being exposed from the risk of being unexposed. So the attributable risk fraction, so that's the first one where you get a percentage as opposed to just decimal places. That's something that confused me when I was doing this, but the first 2, you get answers in decimals, and the percentages ones, well, obviously it's coming as a percentage. So basically it's percentage of cases that can be attributed to the exposure. So that formula is actually quite important. So basically, because I was exposed, then like that's the percentage of cases that, oh no, I said that wrong. Basically, it's just like, because of the exposure, that's how many cases happen. So that's the best way to describe it. And the last one is the population attributable risk and percentage. Again, it's like these formulas is good to remember. So it's basically the risk of the total population minus risk of unexposed. So you're basically finding out what's the percentage risk of just the exposure. So if no one was exposed, how much of the disease could be prevented. So a good example of this is smoking. And I think it's on the next page. Right, so this is a good example to kind of, I guess, explain what I've said, because I just said a lot of words and it doesn't really help explain numbers like that. But if we look at relative risk, you've got risk of exposed over risk of unexposed. Okay, so how do you use these values? If you look at the table, we've got the 3 categories: never smoked, ex-smoker, and current smoker. Okay, and the incidence rate, which is basically how frequently is this occurring in that population. Okay, so the incidence rate for never smoked, 17.7, probably going to be per 100,000 years, but I just cut off the table because I like the shape. And then ex-smoker is 27.9, and current smoker is 49.6. Okay, so how do we find the relative risk? We're going to divide risk of exposed, which is a current smoker, over the risk of unexposed, and you get the relative risk is 2.8. Okay, so that means it's 2.8 times more likely for you to be, or for you to get cancer if you smoke currently, basically, is what it's telling you. Okay, attributable risk difference is you find the difference between current smoker and never smoked, and that's 31.9 per 100,000 person years, which is just the unit that they use. Basically, that's the risk difference, right? And then attributable risk percentage is you take the same value and then you divide it by the risk of exposed. So 64.3% of cases can be attributed to the exposure, is what it's telling you. Okay, so, and then population attributable risk is basically you take value of the whole population as opposed to just the people who have been exposed. Okay, so this is just an example question. These calculations, I don't know, like it might be like one question at the most, but definitely useful for your assignments. So you're going to have an extended project investigation where you have to look at some studies, and you're going to be calculating stuff like risk as well. So just keep these formulas in mind. Okay, so this stuff is definitely very high yield. So if you are going to remember anything from what I've said, this is what's examined a lot. Okay, so Bradford Hill criteria: temporality, does the cause precede the effect? And I mean, I can read all of them, but I mean, you can read it as well. Plausibility, is the association consistent with existing knowledge? Consistency, have similar results been shown on other studies? Strength, what is the strength of the association between the cause and the effect? Sorry, there's a typo there, it should say cause. Does response, does increased exposure increase effect, right? Reversibility, does the removal of the cause decrease the risk of the effect? And strength. Okay, so basically you just need to memorize these because they might give you word associations. So like which of the following is defined as this one? So you're going to need to memorize all of these definitions. Again, it's also useful for your epi assignment, but I don't know how much you guys care about that. Next. So last thing is, this is what the focus of population health is actually going to be on. So all of the stuff I said before is great, but as the weeks progress, you're going to have a much greater focus on this triangle over here. So you've got all of these are different types of studies and levels of evidence. Okay, obviously the highest level of evidence will be the top of the triangle, so randomized controlled trials and meta-analysis. Now in next week lectures, you guys are going to kind of go through a couple of these, and actually probably like your next few lectures are going to be breaking down each of the following studies. So I'll just give you like a little bit of a heads up. There's two types of main studies. You've got observational studies and interventional studies. Now, the majority of studies are observational, which basically means you're just observing what's happened in the population, as opposed to actually creating an experiment and intervening in some way. Okay, so if you go to the higher levels towards randomized controlled trial, meta-analysis, and cohort studies even, you're going to have interventions, and that's why they're considered higher levels of evidence, because you've got a controlled environment and you're intervening in some way to see what changes, as opposed to just observing what happens in a natural population. Okay, but this is always an exam question, so remember that your highest levels of evidence are meta-analysis and randomized controlled trials. But that's it for today. Yeah.
Right, thanks, Pranay. It's going to be a bit of a longer talk for me because we've got quite a chunky piece of anatomy to get through, but I'll be talking about upper limb 1 and 2 today. I understand this is your first piece of anatomy that you're going to go through, so ask as many questions as you'd like, because there's a lot of learning that you'll do in the next sort of 4 weeks about how to study anatomy and how to get it all through your system. So the more questions, the better as we get into today. All right. So to start with the basics, I'd just like to address the pre-learning and the resources that you have. So I'm not sure if it's the same as it was last year, but if you get some David Gonzalez lectures I think there was a couple of sort of textbook excerpts that they wanted us to go through and some Ackland video atlas as well. You're welcome to try it, but there's a thing with anatomy that there's always sort of more information you can know. And personally, I found those really challenging as the first piece of information to go through. And if anything, it's slightly too detailed. So just note that pre-learning definitely isn't mandatory in that respect. And if you find it's taking you a bunch of time and it's not really going in, just be mindful that there are plenty of simpler sites to go to. My favorites are Teach Me Anatomy and KenHub, which are both free and online. I also find it can be helpful for some people to, get a model of a skeleton or one of those apps that go through the human body. And there's plenty of those that you can get online and free as well. Go on, Pranay.
Yeah, so just in terms of free resources, this semester you guys are also going to be learning MSK and cardio. I think for MSK, one of the best resources is definitely Netta's flashcards. So it kind of goes through every single muscle and all the attachments, and that's stuff that you're going to need to know. And also how it's innervated in the arteries as well. And I think the flashcards are a good way to kind of practice getting into the habit of remembering these things systematically. And they are available on the MUMIS Drive. So that's definitely a good free resource.
Yeah, certainly there's plenty of good stuff there. And just to go back a slide, Carrot, there's a few planes that we need to consider as well, which are going to be useful when we think about anatomy. So we have the sagittal plane, which is a sort of vertical plane. If you made a cut down someone's nose, you'd be cutting down the sagittal plane. And of that, a subsection is the median plane. The median being like halfway, it splits you into two halves. So technically a sagittal cut can be any sort of vertical cut, and of which the median plane is one example of a cut in the sagittal plane. Then we have the coronal plane, and the way I sort of remember this is it's also the frontal plane. So if you just took a picture of someone from the front, it's a sort of 2D image along the coronal plane. And likewise, if you cut someone and you cut their front face off from the back of their head, then you'd be cutting down the coronal plane. And finally, we have the transverse plane, which is as if you cut, for example, along the waist horizontally. It's also known as an axial cut. And that it's also a useful terminology to know. And the terminology is going to seem daunting as well. There's a lot of funky words in anatomy that you probably haven't heard before, but just try and have a list of stuff ready when you get into the lecture, and you'll get the hang of it. And it's pretty light work once you are through enough anatomy. The good thing as well is that once you go through upper limb, your lower limb is quite similar. So you'll find it a lot easier to go through. All right, let's jump to the next slide and talk a bit more about terminology. And when we think about anatomy and how we're describing the body, it's useful to just think about a standard position when describing relationships between body parts. Because obviously in different positions, different body parts have different relationships to each other. So we call our standard position anatomical position. And this is basically just standing upright with your palms facing forward. Okay. And we will describe the relationships between parts based on this anatomical position. So the first thing that we need to talk about is superior and inferior. So if a body part is superior, it means higher up. And so, for example, the head is superior to the thorax. And inferior means lower down. So the feet are the most inferior part of the body. Then we have anterior and posterior. So anterior means towards the front. So for example, in this image, the palms are anterior, they're facing anteriorly, and the back of your hands are facing posteriorly, which is where your back is. Okay. So that gives you another dimension that's worth describing. Then we have distal and proximal. So as the diagram points out, I guess distal, you can think about distal as sort of further away from the midline, further away from the core. It gets sort of hard to describe when you talk about structures which are, in your chest, but particularly with your limbs, the furthest parts of your limbs away from your chest are distal. So your wrist joint is distal to your shoulder joint, which we describe as more proximal and closer to the sort of core or midline. Then we have medial and lateral, and they work in a similar way, but slightly differently to proximal and distal. So medial quite literally means closer to the midline, and lateral is further away. So for example, the pinky is medial to the thumb. Even though they're both distal structures, your pinky is closer to the midline of your body than your thumb is in this anatomical position, which is another reason why it's useful to have that standard position. And last of all is superficial and deep. So when we talk about superficial structures, we talk about things that can be accessed more easily. So for example, your skin is very superficial because you can just simply touch it. Whereas deep to the skin, things like muscles, we will describe as deep. So if something lies under a layer, we call it deep. And if something lies above, then we'll call it superficial. So it can be useful to just maybe look at a couple of diagrams and have these words down pat, because they're certainly going to be things that you hear a lot of in anatomy. And another way you'll hear anterior and posterior referred to as ventral and dorsal, dorsal meaning posterior, anterior meaning ventral, and potentially another word for superior and inferior will be cranial and caudal, which is another thing to consider. All right, let's jump to the next slide. And now there's a bunch of fancy words that we need to know for movement. So it can seem daunting, but again, there's plenty of good pictures online. So the first thing we'll start with is flexion, okay? And when you think about flexing, you probably think about flexing your biceps, and just think about what that movement implies. And so when we think about the definition of flexion, it's the movement that decreases the angle between two body parts, and it's often a bending movement. So when you flex your biceps, for example, the angle between your upper arm and your forearm decreases, right? It goes from something like 180, and as you bring it back, it becomes more and more acute. And we can actually flex a whole bunch of joints. This diagram shows shoulder flexion. So I guess here we can think about the angle between the arm and the head. And as you flex your shoulder, that angle decreases. The opposite of flexion is extension. And extension basically means the angle between two body parts is increased, and it's often a straightening movement. Of course, you can extend to counteract flexion, or you can extend from a neutral position to, for example, bring your arm back. There's an issue with saying that flexion always moves things anteriorly and extension always moves things posteriorly, because when you think about the knee joint, you actually flex your knee joint by bringing your leg backwards, bringing it posteriorly and reducing the angle between your sort of calf and thigh. And that's one of the exceptions that you'll find. The next couple of movements that we need to consider, if we jump to the next slide, are abduction and adduction. Now, again, a couple of new words. I guess you can think about abduction. If I'm abducting someone, you take them away. And so abduction is movement away from the midline, right? So if I bring my hand out away from my sides, we describe that movement as abduction. And again, adduction is just the opposite, movement towards the midline. So again, you can do the same thing with your legs. If you do the splits, then you're abducting, and adduction would be bringing your legs back together. Then we have medial and lateral rotation. And as the name describes, just remember medial is towards the midline. So if I'm in my anatomical position with my palms facing forward, if I bring my thumbs in bend my thumbs towards the midline, we describe that as medial rotation. Whereas if you go the other way and, for example, rotate your shoulder around, we describe that as lateral rotation. So those are the main movements that we get. There are other movements that are more specific to joints, but I'll talk about those when we get into the right context. There's a whole range of things that you'll learn about in anatomy, and some things you'll cover in your lectures and some things you'll cover in your tutes, right? And I like to break down anatomy into joints, bones, musculature, muscles, neurovasculature, which is nerves and blood vessels, anatomical areas, and various conditions and other pieces of clinically relevant information. So that's how I'll go through all the topics for today. So we'll start with the joints and bones, and your first lecture, which is upper limb 1, will deal with the pectoral girdle. Okay, the pectoral girdle or shoulder girdle is a group of bones that connect the upper limbs to the bones along the axis of your body, which is sort of like your chest and your torso area. Okay, so when we talk about the pectoral girdle, we're talking about two main bones, the clavicle or the collarbone and the scapula, which is the shoulder blade. And you can see these bones form the connection between the humerus, which is the only bone in your upper arm, and your rib cage, your sternum, which is this bone between the ribs, and the manubrium, which is the upper part of the sternum that you can see touching the clavicle here. So it's two main bones that connect your axial skeleton, your ribs and sternum, with your upper arm. Now, one thing that's important to consider in upper limb generally is we often have a trade-off between mobility and stability. Okay, and what that means is it's useful to have our arms as mobile as possible. Relative to other structures, your arms are incredibly flexible. You can move them in a ton of different directions. And because they're very mobile, the structures can be less stable, right? So you often will dislocate your shoulder a lot more than you might dislocate your hip. And while these structures try and maintain a sense of stability, anything that's more mobile will be less stable, and vice versa. Anything that's more stable will be more mobile. And I've included this picture of the sternum here just to describe its three main parts. It's not super relevant to know it at this stage, but it can be nice to know that there's a manubrium, a body, which is the main section, and a little tip at the end known as the xiphoid process. Okay, so we'll talk about these two bones further on the next slide. And we'll start with the clavicle. Now, there's a bunch of information really around the clavicle. I've underlined the things that you really need to know, which is just 2 points, but there's a bunch of extra points that you can have for your information. I sort of like to think that if you know two pieces of information which are linked, it's a lot easier to remember those two pieces of information. I think most of the time, if you only remember one thing, it can be easier to forget it. But if you remember a piece of information in two ways, or two linked pieces of information, you can often use one to remember the other. And so we'll try and look at that in today's lectures. So the clavicle connects your sternum with, not with your clavicle, with the scapula. And it has a couple of bony landmarks. We have the conotubercle here and the trapezoid line, which are attachments for ligaments, respectively the conoid and trapezoid ligaments. The medial, so the side closer to your midline, the medial 2/3 is formed by a process called endochondral ossification, and the lateral 1/3 is formed by intramembranous ossification. Now, I don't expect you to know what those processes are at this stage, but it can be useful to think that one bone is formed by two different processes, and that actual point of intersection between where those two processes form, which is 1/3 along the way laterally, is marked by this change in concavity, right? So it has a certain concavity for 2/3, and then it changes concavity along the last third. And that middle third, particularly due to that change in concavity, is the third that's weakest and most susceptible to fracture. So, the takeaways are clavicle connects your sternum to your scapula, and the middle third is most susceptible to fracture. And the way you'll fracture your collarbone is most likely by falling onto an outstretched hand. And you'll see this, this type of injury quite a lot. So we're going to refer to it as the PHYS injury. If you do fracture the middle third of your clavicle, I want you to think what would probably happen to each side of the bone, right? So the medial end is attached to a lot of muscles in your neck. And when you have an injury, those muscles will contract and pull the medial end superiorly, so pull it upwards. Whereas the lateral end is connected to a lot of your arm muscles, right? So when they contract, they'll pull it down inferiorly and also medially, as we'll talk about. Pectoralis major also attaches to the clavicle. So often we can combine the words, inferior and medial and call it infromedially. Okay, now we'll talk about the scapula, and it's the site of attachment for many muscles. It sits just behind the ribs, and there's a lot of bony landmarks to look out for, and you'll be talking about these in your CLIN skills classes next week. So a few important landmarks are the acromion, which is a process or it's a bit of bone that sticks out really, and that's located posteriorly. So you can see it better from the posterior view, and it's a big bulge. You can actually feel it if you press around that area. Then we have the coracoid process, which again is a little protrusion of bone, which you can actually palpate and feel as well, and that's located anteriorly. You have the glenoid fossa or the glenoid cavity, which is this sort of socket on the lateral side of the scapula that your humerus sits in, and it's an important part of the shoulder joint. And then we have the spine of the scapula, which, as you can see along the posterior view, runs and eventually turns into the acromion. So those are the main bony landmarks that are worthwhile knowing. We also have the inferior angle, which is just the bottommost part. And the concave surfaces that you see are sites of resting for a few muscles that we'll talk about later. Now, the next thing we need to consider is the humerus. And this, as you can see, the ball, which is sort of around the head, that's the bit that's going to fit in nicely with the glenoid cavity, and that will form the shoulder joint. Okay, it's technically not part of the pectoral girdle because we're just talking about the clavicle and scapula when we address that term, but it's the main and it's the only bone in the upper arm. Okay, so it's important to discuss now. There's a bunch of landmarks that we really need to consider. First of all, we have the greater tubercle. The tubercle is a bit like a bony prominence or a bit of bone that juts out. Okay, and this picture on the left is a posterior view, and the picture on the right is an anterior view. So our greater tubercle is located pretty much laterally and slightly anteriorly, whereas our lesser tubercle is located more anteriorly and more medially, and slightly smaller than the greater tubercle. Between those tubercles is the intertubercular groove, and we also have the deltoid tuberosity, which is located on the lateral side of the humerus, and as the name suggests, that's going to be the insertion point of the deltoid, which I'll talk about further. And there's also a radial groove, which is a little sort of prominence in that shaft of the humerus, which some important structures run in. But the main thing here is hopefully you're beginning to see, and you can see it in the diagram on the left, how the ball of the humerus or of the head of the humerus can articulate or connect with the socket of the glenoid cavity. Right, let's jump to the next slide. And there's a bunch of different types of joints, and this is really just an introduction. You're welcome to have a look at these after I go through them, but there's 3 types of joints by the nature of the actual joint. Okay, so joints can be fibrous, cartilaginous, or synovial. And the 3 different types of joints are made of slightly different material, and they have different roles. So fibrous joints generally don't move, You might get fibrous joints in your spine, for example, which have very little movement. Cartilaginous joints are cartilage joints, and they permit some movement, whereas synovial joints, which are going to be the joints that we talk about today, are freely movable. So for example, your wrist, your elbow, your shoulder, they're all synovial joints. And as I've mentioned before, there's going to be a trade-off between mobility and stability. So these ones are the most mobile. They're also the least stable, okay? There are a few sort of unique features to a synovial joint. First of all is they have a joint capsule, okay? And that's, you can think about it as a bunch of tissue that surrounds the joint. And between, it's not just bone on bone, there's a bunch of structures surrounding it. And for example, housing liquid and blood supply to keep that joint compact. You also have a synovial lining. So as you can see in the bottom left here, we've got a capsule, which is a big sheet around that joint. And under that capsule, or deep to the capsule, is a layer of synovial membrane, okay, or synovial lining. This bounds a joint cavity, which is filled with synovial fluid, and coating each surface of bone are hyaline cartilage. Now, it's normal for synovial joints to have hyaline cartilage. This doesn't make them cartilaginous joints. Okay. Then we'll have subchondral bone, so bone that lies under the cartilage, and there's normally ligaments that support each of these joints. There's also classifications of joints by the movements that they permit, so not by the substance that they're made of. And I'll encourage you to have a look at these. Basically, different types of joints will permit different types of movements, but I'll cast your attention to F, for example, the ball and socket joint. And hopefully you can see the relevance of that, because your shoulder is actually a ball and socket joint. So you have a ball-shaped humeral head and a socket-shaped glenoid cavity, and that's the most mobile type of joint, because that joint can rotate, it can move in any direction. Whereas your least mobile type of joint is probably D, which is your plane joint, and that can only really slide the bones against each other. The other relevant thing to consider is probably your hinge joint in your elbow, which is B. And as you can see with this type of joint, the reason we call it hinge is it can only move in really one direction. So if you think, you can only flex and extend your elbow. You can't really move it sideways because you end up just moving your shoulder. So a hinge joint is another relevant thing, and that only permits flexion and extension. Okay, so two joints that we need to consider, and two joints that are relevant to the clavicle, are the SC and AC joint. SC standing for sternoclavicular and AC standing for acromioclavicular. And this describes the two attachments of the clavicle, one to your sternum and the other one to the acromion of the scapula. Okay, the SC joint is an atypical saddle-shaped synovial joint, and it has articular, means the surfaces that contact other bones. So, or the joint surfaces, the articular surfaces are lined with fibrocartilage, and there's also a fibrocartilage articular disc. Okay, so the reason why it's atypical is because it's fibrocartilage lining the surfaces rather than hyaline cartilage. This SC joint is highly mobile. It permits some of the mobility of the arm and is actually rarely dislocated. So it's one of the exceptions. And there's a bunch of ligaments that support it, which you can find on Teach Me Anatomy. I don't think they're super important. The real thing that you need to know is that it's an atypical saddle synovial joint, and it's atypical because there's fibrocartilage coating the surfaces of the bone. The AC joint is an atypical planar synovial joint. Again, it's atypical because the surfaces are lined with fibrocartilage, and the joint cavity is partially divided by an articular disc as well, which is a wedge of fibrocartilage. Now we have the glenohumeral, or the shoulder joint. And with many things in medicine, the actual words will describe the articulations that you need. So glenohumeral, humeral as in humerus, gleno as in glenoid cavity. So this is the shoulder joint. And you can definitely see well from this picture how it is an actual ball and socket joint. So you can see that ball-shaped head of the humerus articulating with the socket-shaped lateral point of the scapula, which is the glenoid cavity or glenoid fossa. Fossa pretty much means cavity. And it's highly mobile, as I've mentioned. One thing that's worth noting is the humeral head is really large and it's quite a shallow fossa. And if you think about what that implies, if you have a very shallow socket, you have a greater range of movement, but also less mobility. When the socket is deeper, as is the case in your hip, you can move less, but it's also more stable. So the shoulder joint is very susceptible to dislocation, and it's almost always in an anterior and inferior direction due to laxity or looseness of the ligaments. So the ligaments don't support movement in that direction as well. This dislocation most commonly occurs when the arm is extended, laterally rotated, and abducted. Okay. Pranay actually made a good point earlier. Another way of talking about lateral rotation is external rotation. And if you think about your thumb, like if I'm moving it this way, I'm moving it externally. And if I'm going the other way, that's internal or medial rotation, which is something to think about. And the posterior dislocation is common from our PHYS injury. And we've got the three main ligaments supporting the shoulder joint here. The coracoacromial ligament, which prevents the humerus from moving superiorly. The coracohumeral ligament, which prevents it from moving laterally. And the glenohumeral ligaments, which are quite weak. So there's not a whole lot of support in the anterior inferior direction, which is why dislocation is common there. So with shoulder dislocation, the dislocation of the shoulder and a fracture of the surgical neck, they may endanger the axillary nerve, I should say. And the axillary nerve wraps around the humerus here. So if you think, if things are loose or the bone breaks and there's fractures, those nearby structures are going to be endangered, right? So if the bone slips out of the socket and it hits the nerve, then the things that the nerve supplies, the structures that the nerve supplies, aren't going to function. Okay, and we'll talk about this later on, but the axillary nerve supplies the deltoid muscle and the teres minor muscle, so you won't be able to contract those muscles. And it also gives you sensory innervation to an area called the regimental badge, which we can see in this diagram. This is quite relevant. I think most of the stuff in anatomy, knowing the actual anatomical features aren't massively important, but knowing the actual clinical stuff, knowing the shoulder dislocations and the conditions, that's more where you get your marks, right? So shoulder dislocation, particularly, and fracture, particularly proximally, will put the axillary nerve and a couple of arteries, which are the anterior and posterior circumflex humeral arteries, at risk. And I think that's worthwhile knowing. Okay, so we've talked about joints and bones. Now we're going to talk about muscles. So with muscles, there's a couple of things that are worthwhile considering. First of all, their origin is the attachment to the bone that stays still during contraction. And the origin of a muscle is often proximal. Okay, so we have an origin proximally and an insertion distally. And your insertion is the attachment of the muscle to the bone that moves during contraction. So I guess I like to think, if you can think of a muscle as a string and one end of the string is fixed and you sort of pull on the other end, the end that's not fixed is going to move, right? And that's sort of what contracting is like. So with your biceps, for example, the proximal end of your biceps is fixed to the bone, and the distal end attaches to a different bone and actually moves that bone when you contract it. There's also three groups of muscles that are worthwhile considering around the shoulder. And the terminology here actually extends to a bunch of different joints. So intrinsic shoulder muscles originate in the shoulder, right? They're intrinsic to the shoulder. And so they originate from the clavicle or the scapula, and they'll insert on the humerus. And examples of these are the rotator cuff muscles, the deltoid and teres major. Examples of these are the rotator cuff muscles, the deltoid and teres major. Extrinsic shoulder muscles will move the shoulder or have a role in shoulder movement, but they originate outside of the shoulder. So from the torso, and they'll attach to the bones of the shoulder. So these include the superficial back muscles. And finally, axio-appendicular muscles originate from the torso and attach to the bones of the shoulder. I guess the difference between axio-appendicular and extrinsic is these are more your back muscles, whereas your axio-appendicular muscles are located around the front. Okay, so we'll go through each of these sets of muscles. I think the rotator cuff is probably the most important set. And so that they're composed of 4 muscles, which have the role of stabilizing the shoulder. And each muscle moves the shoulder in a slightly different way, but their main role is maintaining stability. These muscles are the subscapularis, supraspinatus, infraspinatus, and teres minor. Okay. I guess the way you can remember them is they pretty much each sit in a scapular fossa, except for teres minor. So when you think about the scapula, if you can remember the anterior surface, which is curved, that anterior surface is actually where subscapularis sits, right? If you can remember the posterior surface, there was a part below the spine and a part above the spine. And the part above the spine is where supraspinatus sits. Supra meaning above, spine meaning spine of scapula. And infraspinatus is below the spine. And you can see it on the diagram here that that bone is the spine of the scapula, and supraspinatus sits in that fossa there, and infraspinatus is below. And teres minor sits sort of on the lower border of infraspinatus and attaches actually to the inferior angle of the scapula. It's worthwhile considering their actual insertion can be memorized pretty easily by the sits mnemonic. And so we have sit on the greater tubercle with supraspinatus, infraspinatus, and teres minor, which are all your posterior muscles, whereas your anterior muscle, subscapularis, inserts on the lesser tubercle. Okay, and the roles sort of match their position, right? So you can think about supraspinatus, that's the most superior muscle. That's going to have a role in bringing the shoulder up in abduction. Infraspinatus and teres minor, they sit quite close to each other, so they actually have the same role. And because they insert on this greater tubercle from the back, when they contract, you'll actually rotate your shoulder outwards. So they have a role in lateral or external rotation. Contrary to that, subscapularis is located anteriorly to the scapula and inserts on the lesser tubercle, which is also located anteriorly. So when that contracts, your shoulder is actually going to be rotated medially or rotated inwards, and your shoulder can actually be brought inwards as well in a movement which is adduction. So I think all of that's worthwhile knowing because you're going to be examining the rotator cuff quite a bit. Tendinopathy is inflammation of these rotator cuff tendons, and tendon is often the distal sort of attachment of the muscle, and we can inflame our tendons by overuse. And often rotator cuff tendinopathy occurs due to overuse above the horizontal, so above your level of your shoulder. So particularly swimmers experience rotator cuff tendinopathy quite a bit. The muscle most commonly involved is supraspinatus, and its tendon runs in the enclosed subacromial space. So subacromial meaning below the acromion. So if we think about the acromion here, we have a bursa here, which is a sac of fluid that acts as a cushion to reduce friction between the tendon, which lies underneath it, and the bone, which is the acromion. So there's quite a narrow portion of space there. And when you overuse the muscle, there's a lot of rubbing that goes on, and you get inflammation of that muscle. And you'll experience pain between 60 and 120 degrees of abduction, and you'll assess that in a test which we'll talk about in future weeks called the painful arc test. Okay, the other two intrinsic muscles that we need to talk about are the deltoid and teres major. The deltoid is your sort of traditional shoulder muscle, and it originates from your clavicle, acromion, and scapula, and inserts on the deltoid tuberosity of the humerus. I find with muscles, you don't really need to know the origin and insertion for every muscle. I think it's better just to have a rough idea of where the muscle sits and probably what it does. If you're going to know anything, I think know the insertion, because if you know where it inserts, it tells you a lot about what the role of the muscle actually is. Okay, so there's a bunch of different parts of the deltoid muscle. So the clavicular or anterior part will flex and medially rotate the arm. The acromial or middle part will abduct the arm, and the spinal or posterior part will extend and laterally rotate the arm. So it's such a big muscle. If you think about the direction in which the fibers run, and if you pull down on each of those fibers, if you pull down from the front, you're going to move your arm inwards and move your arm forwards. And if you do it from the back, it's going to be the exact opposite. So there's a bunch of different roles, but if you can visualize where the fibers are running, it helps you work out what those roles are. Teres major originates from the posterior surface of the scapula. So we can see we're on the posterior surface because we can see that spine of the scapula here really well, and the acromion as well. Okay, so teres major originates from the posterior surface of the scapula's inferior angle and inserts on the medial intertubercular sulcus. I think the insertion is important here because if you can remember, it inserts on the medial intertubercular sulcus. If we pull the medial end, and you can see it's the anterior humerus as well. If we pull that, we're going to pull the humerus internally. So there's a role in medial rotation and also closer to the body as well, which is a role in adduction. Whereas if it, for example, inserted on the greater tubercle, then it would probably have a role in external rotation and maybe extension as well. So it's all about, if you can picture where it inserts and picture pulling, pulling the proximal or pulling around the origin and thinking about what happens to the insertion when it's pulled, then you can visualize the role of the muscle. Okay, we'll talk about, this is a nice table actually with the origin, insertion, innervation, and function of each of the muscles. And I guess you can use that for your notes. I've got one of them for each of the group's muscles as well. All right, let's talk about the extrinsic back muscles. And there's about 5 or so that are worthwhile considering. They're actually split into 2 different layers. So the superficial layer is on the left here, and the deep layer is on the right. You will talk about these muscles when you do back anatomy around the mid-sem break. So if you know them now, you'll be good then. If you don't know them now, then you'll get a refresher then. So your superficial muscle is your trapezius and your latissimus dorsi, or your lats. Your trapezius is a massive muscle, which has a bunch of different roles. And again, lats are another one where if you remember the insertion, you can remember its role. The deeper layer is composed of levator scapulae and the rhomboids, so minor and major. You would note there's a few muscles that have minor and major, and whenever there's a minor, there's a major. Okay. And I think with muscles, if you know their innervation as well, or which nerve supplies them, that's also really useful. So it's now at this stage where I'll introduce another movement to you. So we've had flexion, extension, abduction, adduction, and then internal and external rotation. Then with our scapula, we can have elevation and protraction. So elevation, as if you think about an elevator, it moves it in a superior direction. So it's the opposite of depression, which is moving it downwards. And then we have protraction, which is anterolateral movement of the scapula on the thoracic wall and allows the shoulder to move anteriorly. So you can imagine the rib cage, and the scapula sits behind the rib cage, sort of and it's a shoulder blade, so it's sort of concave and sits behind it. Protraction moves the scapula around, and if you think about what needs to be done when you're sort of moving your arm around here, your shoulder blade comes across, and we call that movement protraction. And if I moved it back and I pressed my shoulder blades together posteriorly, that movement is retraction. All right, let's jump to the next slide. Here are the attachments, blood supply, innervation, and action of each of the muscles. You don't need to know the blood supply, but I think the rest is definitely worthwhile having a look at. We'll now talk about axio-appendicular muscles. So remember, these muscles sort of originate from your anterior chest and will insert on your humerus. So the axial skeleton is the bones of your head, neck, back, and chest. So they're all sort of midline structures. Or your appendicular structure, appendages is like things that you add on or stick on. There's the bones that attach or append to the axial skeleton. So your limbs, pretty much. Your superficial axio-appendicular muscle is your pectoralis major or your pecs, and your deep layer is composed of pec minor, serratus anterior, and subclavius. Okay. Again, I've got another table that's worthwhile considering. I think with the distal attachment, which is the insertion, if we just talk about the pecs for a minute, they insert on the lateral lip of your intertubercular sulcus. So if you think they originate anteriorly, they're going to insert on your lateral intertubercular sulcus, which is located sort of anteriorly and a little bit laterally. You know, when they pull, you can figure out that there's going to be a bit of adduction because, you know, it's pulling towards the middle, and there's going to be a bit of medial rotation as well. And if you can remember, when we fracture our clavicle in the middle third, the pec major is what's sort of acting on the lateral third, and that's why it's sort of pulled medially. Okay, and I've got images of the previous three muscles on the previous slide, and here's a table with their action. Serratus anterior is probably the other one I should address, and that is the muscle that actually is responsible for protracting the scapula, holding it against the thoracic wall or the rib cage, and moving it around anteriorly. So you see here, when that contracts, the shoulder blade can move around the ribs and come forward, whereas the rhomboids, which were the back muscle, actually do the opposite and move it backwards. Thanks for that, Carrot, and we'll jump to the next slide. Okay, so we've done joints, bones, and muscles. Now we're heading to neurovasculature, which is the fun stuff. I'll go over the basics of the nerve quite quickly. If you can remember, dorsal and ventral are the same as posterior and anterior. So we often use dorsal and ventral when we talk about the spine. We have dorsal and ventral ramus. Ramus means branch. Okay, so dorsal rami innervate your intrinsic back muscles and your back skin. They're not very significant, but they come from the back. Ventral rami innervate the rest of the body. So everything we talked about today, including the superficial back muscles, are innervated by ventral rami. Your intrinsic back muscles are different to the ones we've talked about. Okay, so even though it's a very small portion, I mean, it looks 50-50, the dorsal ramus is actually only innervating a very small portion. And so we have blue, which is your sensory nerve, coming in from ventral and dorsal rami. They go through the dorsal root, and then they come into the spinal cord, and they'll often go up to the brain. Brain will send messages down, and we have motor neurons coming through the ventral root, and then they'll go through the ventral and dorsal rami respectively. Awesome. Now, this is where nerves can get slightly more complicated. So we have something called the brachial plexus. And I'd encourage you, if there's a medical word that keeps popping up, try and look into its definition. So brachial, you'll see it quite a lot, sort of means arm. There's a bunch of muscles that have brachii in the name. Plexus is a network of nerves or vessels. So the brachial plexus is the network of nerves, in this case, that goes to your arm. And it's a network made up of the anterior rami. Remember, anterior rami, pretty much what we're concerned about until you hit back anatomy. Anterior rami of C5 to T1. So your spinal cord has 4 main sections: cervical, thoracic, lumbar, and sacral. And each section has a bunch of different vertebrae and a bunch of different nerve roots that come through each vertebrae. And the roots we're going to look at are C5, C6, C7, C8, and T1. I haven't included on the slides, but it's worthwhile knowing that there is a CH root, but there's no CH vertebrae. And it's the only example that actually happens in the spine. And I'm sure you'll talk about that plenty over the semester. Okay, so roots start from the spinal cord, and when nerves emerge from the spinal cord, we call them roots. They then combine, so C5 combines with C6 to form a superior trunk. C8 combines with T1 to form an inferior trunk. Each trunk splits into anterior and posterior divisions. The posterior divisions form to be the posterior cord, and the anterior divisions of the middle and superior trunks make the lateral cord, and the inferior trunk sort of continues with its anterior division to become the medial cord. And then those cords become branches. Now that's a lot going on. I'd suggest make a mnemonic for roots, trunks, divisions, cords, branches, RTD, I think you need to know the order. I don't really think you need to know like the actual map of how to draw this out. Exam questions are multiple choice. But you definitely need to know what roots are involved. I think it can be useful to know these branches, and also knowing what roots are actually mainly involved in what branches. For example, this ulnar branch is fed into by the C8 and T1 roots. That's relevant. Whereas all the stuff in the middle, not so important. What is really important, and particularly for things like dissections, is the M that you get between the musculocutaneous, median, and ulnar nerves. So if you draw from musculocutaneous to that intersection, and then down to the median, and then up to the intersection, pretty much where it says medial cord, and then down to ulnar, you get an important M, which is most of the time there and a really good landmark to tell where in the brachial plexus you are. Yes, exactly there. So we jump to the next slide. I've got a couple of diagrams for the brachial plexus. You can see the M a little bit better here. And I mean, if nerves aren't arranged this sort of nicely in real life, but you can sort of see in this graphic the M as well between the musculocutaneous, median, and ulnar nerve. Yeah, exactly. There's a bunch of branches along the brachial plexus. I don't really think you need to know all the branches, all their roots, you know, what part of the cords they come from. But I think it's worthwhile just having a look at all the nerves, because every nerve that comes off this brachial plexus will innervate a muscle that we've talked about today. For example, the long thoracic nerve, which has fibers from C5, C6, and C7, that innervates serratus anterior. So you'll probably learn about the bulk of these nerves, and they'll innervate a muscle that we've talked about, but you don't really need to know whereabouts they branch from. What I would recommend you take away from this slide is the actual nerve roots that contribute to each of the nerves. So for example, musculocutaneous nerve is C5, C6, C7, axillary nerve is C5, C6. That I think is important. All right, let's jump through to the next slide. Now we have dermatomes, cutaneous innervation, and myotomes. So you'll talk about this a little bit in your lecture. The dermatomes is an area of skin that's mainly supplied by a single spinal nerve root. So just one root. So for example, we have a dermatome map of the arm, and for example, your thumb is in the dermatome C6. So the skin around your thumb is mainly supplied by the spinal root C6. And if you had an injury around your C6 nerve root, your sensation around your thumb would be compromised. And I think it's useful to know, because when we do examinations of people's nervous systems, we check each dermatome to see if the sensation is normal. Cutaneous innervation is the area of skin supplied by a specific cutaneous nerve. So for example, the median nerve, which is one of the branches, will supply the bulk of skin along your hand. So in a cutaneous innervation diagram, every single nerve has its own patch of skin that it innervates. So cutaneous innervation deals with the area supplied by a whole nerve. Dermatomes is just by one root. And a myotome is the movement or group of muscles mainly supplied by specific spinal nerve roots. So for example, shoulder abduction, that movement is mainly supplied by a couple of nerve roots, right? Moving your hands in and out, that mainly involves the root T1. Moving your fingers up and down, mainly the root C7 and C8. That can be really tricky to memorize, but normally they sort of go down in a sequential order. So if you look at the relationships between the numbers, there's generally something there, but that might be something you need to know for your neuro exam if you do it in a OSCE situation in maybe year 2, if not year 1. Okay, so that's nerves. Now we'll talk about arteries. So there's a bunch of arteries, and it can be easy to go into too much detail, but think about the main arteries, and there's probably only 5 or so that you need to know in the whole arm. And it's often one artery that has different names at different sites. So it starts off as the subclavian artery when it goes under the first rib. Okay, so sorry, the subclavian artery branches off from the brachiocephalic trunk on the right, which we'll talk about later. But the part until the first rib is called the subclavian artery. After it goes under the first rib, it becomes the axillary artery, and it runs in a space called the axilla, which we'll talk about. After it exits the axilla at the lower border of teres major, it becomes the brachial artery. Remember, brachial as in arm. So this is the artery that runs in the arm. Okay, and it runs in the arm until another space called the cubital fossa, which we'll talk about later. The cubital fossa is sort of located just anteriorly to your elbow. Okay, off the brachial artery, we have the deep brachial artery, which runs through the radial groove with the radial nerve in the radial groove, which is that protrusion in the humerus. Okay, so if you fracture your radial groove, it carries your deep brachial artery and radial nerve, which are at risk of damage. We also have the posterior and anterior circumflex humeral arteries, which branch off the axillary artery, and they run with the axillary nerve around the neck of the humerus. And those were the ones that I mentioned were in danger when we have shoulder dislocation. The deep veins run with these arteries and have the exact same name. So veins are generally pretty simple to know because deep veins have the exact same names as the artery and run exactly with them. However, a couple of veins are what we call paired veins. So brachial, ulnar, and radial veins are paired veins. And what that means is there's 2 veins for one artery. 2 veins run either side of the artery. And whenever the artery, pulses, because arterial flow is pulsatile because of the heart, the pulses will actually create pressure changes in the veins that allow blood to move through them more quickly. I should also mention that the brachial artery at the cubital fossa splits into the radial and ulnar arteries, which are your main arteries of your forearm. And that's really what you need to know in terms of arteries. Jump to the next slide, and we'll just talk about where the actual subclavian arteries come from. So again, this is slightly more than you need to know, but by the end of the semester, you'll know all of this. So you have your left ventricle, which is part of your heart. That gives off the aorta, which is the main blood vessel in your chest. From the aorta, the left subclavian artery comes directly off this arch, whereas on the right, we have the brachiocephalic trunk, which branches into the right subclavian and the right common carotid. Okay, so left subclavian straight off the aortic arch, right subclavian comes off the brachiocephalic trunk. And then from there, it's all symmetrical. Your subclavian arteries go until under your first rib. Under your first rib, they become your axillary artery. Then from down the axilla, they're your axillary artery. Then into your arm, they're your brachial artery. And they eventually become your radial or your ulnar arteries. And they cross over in your hands as the digital arteries and have mixed blood supply there. All right, let's jump to the next slide. And I mentioned deep veins run with arteries, and that's because we have a bunch of superficial veins. So you may look, if you can look down at your arms, if you see a bunch of veins there, like they're all veins, there's no arteries there. And they're superficial veins that run in what we call the subcutaneous tissue, which is under that initial layer of skin, which is cutaneous, subcutaneous tissue houses these superficial veins, and they don't have any corresponding arteries. We have perforating veins which connect our deep and superficial veins, because we'd have massive veins pretty much if we didn't drain all the blood from the superficial veins into deeper veins, and drainage wouldn't be as quickly. But the major superficial veins you need to know are the cephalic vein and the basilic vein. The cephalic vein runs laterally from the dorsal of the hand, which is the back of your hand opposite the palm, up until the brachial vein. Okay, whereas your basilic vein runs medially from the dorsal hand as well. The basilic vein goes to the brachial vein, and the cephalic goes to the axillary vein. So the cephalic vein is much longer, and it runs in what we call the deltopectoral groove, which is between the deltoid and the pec major. And you can sort of see the outline of that groove around the shoulder here. Okay. Between those two veins, we have the median cubital vein, which connects the two. That runs in the cubital fossa, and it's the most common site for venipuncture. So when you need access to a vein. And just, you may have noted that when we talk about arteries, we say arteries start proximally and they have branches. Veins start distally because they drain towards the heart. And we say they have tributaries or streams, right? So like a main vein might have a bunch of different streams or tributaries which drain into it, whereas the main artery might have a bunch of branches that send blood away from it. So that's something to keep in mind when you note the terminology that you use. All right, so now we're done with joints, we're done with bones, we're done with muscles, we're done with neurovasculature. Now we've got to get into spaces. And I've mentioned the axilla before. It houses the axillary artery. And basically it's a pyramidal space, which is sort of deep to your armpit. And if you look where it starts and finishes, it's going to house some pretty important structures, right? So this apex of the pyramid, which we call the axillary inlet, sort of the inlet to the axilla, is bound by the lateral or outside first rib, the superior or upper scapula, and the posterior or backward clavicle. Okay, the lateral border is the intertubercular groove of the humerus. The medial border is serratus anterior and the rib cage and intercostal muscles. They're the muscles between your ribs. The anterior border is pectoralis major, minor, and subclavius. The posterior border is subscapularis, teres major, and latissimus dorsi. And the base is the skin, subcutaneous tissue, and axillary fascia. So just your armpit, pretty much. Okay, so there's a bunch of different borders. I don't really think you need to know the borders that well. You can sort of just guess from where the structures are. I do think the apex is worth knowing though, because that's important in the sense that if a bunch of structures go in the apex and will exit, around the base or lateral wall. But it's good to imagine that's the shape of the axilla and that's where it sits. So those are the borders, and the reason it's important is it transmits a bunch of really important structures, right? So the brachial plexus goes through the axilla. The axillary lymph nodes, which we'll talk about, are in the axilla. The axillary vessels, so your arteries, veins, and any branches are there. The short head of biceps brachii, talk about biceps next week, and the coracobrachialis, which is another muscle we'll talk about next week. They're all in this axilla. And you'll note that the brachial plexus wraps really nicely around that axillary artery. And bonus points if you can spot the M of the brachial plexus there, right? So think about axillary artery and vein are named so because they're literally in the axilla, right? So the subclavian artery and subclavian vein go to your first rib. After your first rib, the axilla starts and they become the axillary artery and vein. After exiting the axilla, they enter your arm and they become the brachial artery and vein. So really, there's not a whole lot to memorize because it makes sense if you understand why they have that particular name. All right, let's jump to the next slide. I mentioned axillary lymph nodes before. Basically, when your tissues, like they're undergoing a bunch of different processes, right? And they have nutrients which you get from blood, like your oxygen, any nutrients carried in the blood. And veins drain some of the waste, but lymph drains the rest. And it's probably worth looking into lymph and just doing a bit of reading on it, because I had no idea what lymph was when I started med. But lymph drains your tissues pretty much, and veins drain some. Veins more drain sort of unused blood and unused nutrients. But once your cells, go through their processes and produce waste, your lymph drains the actual extracellular matrix and things like that. And lymph vessels drain into a bunch of lymph nodes, which have some immune cells and filter your lymph. And lymph nodes in the axilla are really important. And there's probably 5 main groups of lymph nodes that you need to think about. Pectoral nodes, which lie anteriorly. Again, this is actually the shape of the sort of axilla, right? So you have your pectoral lymph nodes, which drain your anterolateral superficial abdominal wall and the outer quadrant of your breasts. So it's really like their position in this pyramid matches where they drain, right? So pectoral nodes, think where your pecs are, they drain around that area. Your humeral nodes or your lateral nodes, they drain your upper limb. Subscapular or subscapular or posterior nodes drain your superficial back. The central lymph nodes receive lymph from all of these sites. So they're straight in the middle of that pyramid. They'll send it upwards to apical lymph nodes, and which will send them to subclavian lymph trunks, and your lymph actually gets dumped back into your subclavian veins, which will then take it back to the heart. Okay, lymph is important because a major route of cancer spread is via lymph, right? And if you think about breast cancer, if that gets drained into these lymph nodes and then sent into the subclavian vein and into the heart, that's how it spreads to a bunch of different other sites. So after the heart, it can go to many different areas. So often when you have cancer, you'll have enlarged lymph nodes, which is something that we look for. Okay, a couple of more minor important anatomical spaces that we need to think about. So we have a couple of openings in the axilla, because not all structures are going to enter or enter via the apex and leave via the base into the arm, right? Because we still need things to go to the back and things to go to the pecs. So we have an anterior opening called the clavipectoral triangle, or the deltopectoral triangle as well, because it's bound by the deltoid, clavicle, and pectoralis major, and it transmits the cephalic vein, which runs in the deltopectoral groove. And we have a bunch of openings posteriorly, which are called the quadrangular space, the triangular interval, and the triangular space. Okay, and you can see them here. I mean, they sort of resemble the shapes that they're named after, and they have a lot of shared borders. So if you can sort of remember that, triceps is important, teres major is important, and that the sort of scapula is important as well. If you can visualize it, then that helps, but it's worthwhile looking into the actual boundaries. But more importantly, I think the quadrangular space is the important one. And basically the axillary nerve, posterior circumflex vessels, they leave the axilla via that space to wrap around the neck of the humerus. And so those are the structures that are at risk of shoulder dislocation, puts them at risk. And the triangular interval, that provides a pathway of exit into the posterior segment of your arm. And so the structures that will go there are the radial nerve and profunda or deep brachii or arm artery. Okay, let's jump to the next slide, and we'll just run through a couple of conditions which I think are relevant. Thoracic outlet syndrome, or TOS, is basically when the neurovasculature between your clavicle, your collarbone, and your first rib becomes compressed. It mostly impacts nerves, I think 95% of the time, and is then called neurogenic thoracic outlet syndrome. You can get thoracic outlet syndrome from a bunch of different things: trauma, anything that alters the position of your ribs or bones. So trauma, repeat injuries, anatomical defects, including an extra rib, and even pregnancy as well. And last of all, we've got a little bit of anatomy of the breast. So it overlies the 2nd to 6th costal cartilages and superficially to pectoralis major. So we have the breast here, and the muscle that you can see under it is pectoralis major. So using an anatomical terminology, that lies deep. The breast is composed of a circular body and an axillary tail, which sort of runs towards the axilla. It has 15 to 20, or it has mammary glands, which produce milk, which consist of 15 to 20 secretory lobules drained by a lactiferous duct. So a bunch of lobules produce a product which is drained by lactiferous ducts towards the nipple, and that's surrounded by the areola. We have sebaceous glands in the areolae, which enlarge during pregnancy and secrete an oily substance that acts as a protective lubricant. And when we think about the breast, we often think about it in 4 quadrants. And why is that relevant? Because the 4 quadrants have different lymph supplies and different neurovascular supplies. So if you have enlarged lymph nodes in your axilla, you're thinking that the cancer probably came from the lateral breast. And yep, we'll jump to that. It looks like we're all done. One thing I haven't talked about is the MSK history. So I might get you to stop share, Cara, and I'll bring that up. And it's a short thing just to finish off on. In your CLIN skills tute, you'll cover it, but a systems review is sort of the last piece of history that you haven't added on yet, right? So you have your introduction, you ask your history of presenting complaint, WWQQ, PHYS, and then after you get that, we want to ask a couple of relevant questions to do with the actual system that we think is going wrong, right? Because let's say you think there's a broken bone, there could be other things going on, and you might want to know more than just, I've got pain in my arm. You might want to know a couple more things to potentially even look into other diagnoses. So a systems review is a targeted set of yes or no questions relevant to a specific system. You use it after your WWQQ PHYS, and once you learn about multiple systems, sometimes you'll need to ask about questions from a bunch of different systems. Because if they've got pain in their chest, for example, a whole bunch of systems can cause chest pain. And after your systems review, you go into your past medical history, family history, drugs, and social histories. So with your histories, I think there's a lot of questions in systems review, and there's a systems review for every system. So I like to group all the questions into sets. And if you can roll through your systems review questions, it makes your history so much easier to finish on time. It's also worthwhile just thinking about the way you phrase your history questions. If you yourself are wouldn't understand that, then make it more simple, right? It's all about just simple communication. And sometimes you have to think about whether each WWQQAA question is appropriate for some certain conditions, right? I sort of ran into this problem last year where it's like, let's say you have palpitations or abnormal awareness of your heartbeat, and you're like, oh, could you rate that on a scale of 1 to 10? And it doesn't really make sense, right? So sometimes, like for pain, all of these work, but for a couple of other conditions, it might not be the best. Like if someone's got a cough, it can be hard to rate a cough from 1 to 10 or something like that. So these are the systems review questions that you need to ask for MSK. And I encourage you to think like, what musculoskeletal conditions can actually happen? Like the thing like fractures, inflamed tendons, bruising, swelling, pulled muscles, and things like that. So when you think about like the potential issue, then the sort of questions that you ask make sense. How I like to remember these is in a couple of different sets. So the first set I'd like to do is the PSS step. Some people remember this is like PS2. And so you ask about pain, ask about swelling, and ask about stiffness. Then there's 2 loss questions. So loss of motion, loss of function. Then I try and remember just WID. I don't know if that is the actual thing, but WID. And then the last 2 are your sensation and systemic features. They both start with S. So those are the groups I'd use, but people have different mnemonics for it. The main ways you can remember these questions in a way that you can sort of go through them fairly quickly. So you're asking about pain. Referred pain is pain in a different part of your body. Sometimes, like if your elbow, there's an issue with it. If there's a nerve that's been damaged, you might actually get pain in your shoulder, for example. Swelling, stiffness, you want to ask about if there's stiffness in the morning or stiffness after activity. And if there is, how long does it last for? Because you're thinking potential arthritis or joint inflammation with those ones. Loss of motion, can you move it normally? Loss of function with your daily activities, is your injury impeding you? Is it causing you difficulty? Does it still work normally? Weakness, instability, does it feel unstable? Deformity means, does it look different? Changes in sensation, have you experienced any abnormal sensations in your arm, things like pins and needles? You're thinking, potential nerve injury there. And systemic features are things that you ask in every single history. You often get these sort of symptoms with things like cancer, where it's like you can have fever, fatigue, weight loss, appetite change. Like they're generally things that you ask all the time. But the main thing is try and group the systems review questions into a couple of sets that you can ask. There's a few other questions that I think are worthwhile asking in a MSK history. So handedness, for example, if I break my left humerus, if I fracture it, I think it's relevant that the doctor asks what my dominant hand is, right? Because if I've injured my dominant hand, it's going to be a lot harder for me to go about my daily life, and I might be exacerbating the problem if I still need to use that dominant hand. So ask about their preferred hand. Ask about the position they were in when they injured it, or the action that they were doing, because that can give you a bit of context if it's a muscular injury. How do you use that body part regularly? If they have rotator cuff inflammation, you might want to know if they're swimming or working a lot, maybe as a builder, a lot of work above the horizontal. Hobbies and occupations relevant, because for example, if they're a swimmer, you might need to take a break to rest the rotator cuff. And if there's things like joint pain, you want to ask if that's worsened by activity or weight and relieved by rest, or if the pain is worse on rest and then improves with activity. Last of all, probably the sound of the injury might be something you ask about. Bones tend to snap, whereas the crack or pop is more of a soft tissue injury. So there's a lot to get through there with anatomy, and that's probably half the battle. And we'll talk about the sort of upper arm, forearm, and hand next week. But there's a lot there, and it's going to seem complicated at first, and especially with the terminology, it'll be hard at the start. But you'll get used to it. Again, if you have any questions, feel free to let me know. Happy to answer as many as you have. But yeah, thanks very much for coming, guys. And that's all for today. And I'll see you all next week.